Hello, Assalamu alaikum, dear brothers and sisters. Today, inshallah, we will proceed to the pharmacotherapy introduction. And for our topic today is about hypertension pharmacotherapy. Our learning outcome for today, we want to discuss hypertension, definition, staging, classification in the context of the cardiovascular risk factor. Also want to describe what actually we have as drug and non-drug recommendation for management of hypertension. We want also to highlight the treatment algorithm highlighted in the national and international clinical practice guidelines. And of course, we want to focus on how the proper selection of the medication affected by the presence of comorbidities. In terms of definition, hypertension can be defined as a persistent that's very important, persistent elevation of either the systolic 140 millimeter mercury or more, diastolic 90 or more, taken at least twice, and this have done in two separate occasions, and the recommendation for the proper measurement of the blood pressure also can be highlighted in a few minutes. We have also isolated systolic hypertension, and from the definition we can understand this isolated refer that the systolic blood pressure mainly will be elevated, and this common in patient relatively old, 50 or more, and in general it has poor prognosis. Also, we have what we call isolated office hypertension, or white coat hypertension. White coat hypertension means elevation. This persistent elevation happen only in clinic. And on the other hand, the ambulatory or the home blood pressure measurement are normally or need to normal. We have also the other way around, the masked hypertension. Masked hypertension refer to a normal clinic blood pressure, but in home it is quite elevated, and the prognosis in this case will be worse compared to the isolated office hypertension. Epidemiological data. Here we want to highlight where the hypertension statistics. Okay, so in the first place, we can see on the left side this hypertension at a national level. It is one of three major cardiovascular risk factors, and the cardiovascular disease is a leading cause of the mortality in the national level. And we can see this, maybe the three factors together can affect up to 1.7 million, and at least two of them coexisting in 3.4 million. This in terms of the cardiovascular risk factor. In terms of more specific related to hypertension, hypertension prevalence is about 30%. Means in every 10% we have 3 hypertensive. This, of course, the prevalence increasing with age, and it affected by gender, where the males are 3 times at risk to be diagnosed with hypertension compared to females. What may be alarming in the statistics of management of hypertension, we can see among those who the hypertensive patient only have awareness they are hypertensive. Okay, and from this half we have 90% on medication. From this 9%, almost half of them have the attainment of the blood pressure control, the target level, and this very alarming findings. Hypertension classification and staging. Actually, this table show for us the classification and the prevalence, this at the national level in Malaysia. And we can see from this table that up to 130 to 139 or 85 to 89 diastolic, it is still not classified as hypertensive patient. Okay, and this category at risk in the international guidelines, they term it is as high normal. Okay, among the hypertensive patient, we have stage 1 or grade 1, we have stage 2, and we have the severe hypertension as shown in the table. It is also good, this according, of course, to the clinical practice guidelines, national one in 2018. Also, we have the international hypertension guidelines 2020, and in this one, we can see here the hypertension grade 1 and 2 is parallel to stage 1 and 2, and the at-risk class of patients or at-risk class of individual here termed as a high normal. Okay, here we have this recommendation regarding the blood pressure measurement. We can see here how the back and feet should be supported, what actually the recommendation regarding the room, the comfortable room and temperature, refraining from any coffee, exercise and smoking, relaxing before, take 3 measurements in 1 minute interval, and the average of the last 2 measurements. This actually very important recommendation to make the assessment of the blood pressure is credible and guiding the classification that we highlighted before. Here we can see this very important point before proceeding to the medication, to know the basis of the assessment of the hypertension in a given case. So the evaluation of the documented hypertension has to address 3 important objectives, 3 main objectives. The first one, we have to take care or exclude a secondary non-causes of hypertension, either as a medical condition or as medication. Also, we have to assess to ascertain if there any target organ damage or complication in a given case. This will guide also the treatment. And what about the other cardiovascular risk factor? It is very important. Other risk factor and the lifestyle of the patient also can be integral, affecting determinant in guiding the choice of the treatment. We will take one by one. First, the secondary causes of hypertension, as I mentioned, we have medical, you can see here the medical condition, some medication induced, and this one actually, it is far more than this one, this IMPRIV from the national guidelines, but it is far maybe beyond this one in terms of number of medication that can affect the blood pressure, and of them, of course, we have the non-steroidal, we have the steroids as a common one. We have the Cushing syndrome. This may be a syndrome with we have high cortisol levels, or maybe due to long-standing corticosteroid administration, for example. We have the tumor of adrenal gland, the pheochromocytoma. We have thyroid disease, and we have some congenital abnormalities in the aorta also as a causes. Second point, the presence of the target organ damage and target organ complication. And in this case, we have maybe the heart, brain, retina, and kidney, and even the peripheral vasculature can be affected all by the long-standing hypertension, and this can manifest it in many ways. Can manifest it as a damage, can happen as left ventricular hypertrophy or retinopathy or proteinuria, or a complication where the renal and heart failure can take place. Third point, related to the risk factors. And risk factors, we have to assess whether hypertension alone or hypertension as a part of a portfolio of other cardiovascular risk factors such as diabetes, dyslipidemia, smoking, microalbuminuria or proteinuria, and estimated the GFR less than 60. We have to look for this one, and the presence also can impact on the treatment and impact on the starting recommendation in a given case. Okay, coming to this point of the risk stratification, where most of the cases will be stratified, and according to this stratification, the treatment will be built on. So we can consider risk stratification is the basis for therapeutics to be there. Okay, and for this risk stratification, we have this figure on the right and the left side from the national guidelines, where the classes of the hypertension, including the at-risk population, including the severe hypertension, are all matched against the presence of coexisting medical condition with the consideration of the risk factor, the target organ damage, the target organ complication. Here the risk factor 1 or 2, the risk factor more than 3, and here we have already cardiovascular disease, already a patient have CKD, diabetes, or stroke. We can see here the classification either low, intermediate, medium, high, and very high. Okay. On the other hand, the international guidelines have included the high normal, grade 1 and grade 2, and they didn't mention in the risk stratification the last category of the severe hypertension, because it is more or less have some specific recommendation for the management for this category. Here the idea is the same for the high normal, and according to the risk factors, no or 1 or 2 or 3 or more, or hypertension mediated organ damage, same, CKD stage 3, diabetes, cardiovascular disease, the patient will be categorized. And you can see here all this category, high, referring to taking into account the major blood pressure and the risk factor. Means patient in grade 2 mostly if no other risk factor, they have at least moderate to high risk, okay, which is very high. Where the patient with 1 or 2 risk factors, they can have or classified as high risk patients if only they have maybe grade 2 hypertension. With the patient more than 3 risk factor, grade 1, they have high hypertension, and of course those with hypertension mediated organ damage, all category, even the high normal, even the at-risk population will be classified as high risk. So based on the risk stratification, we can see how the treatment will be recommended. So according to the risk level, almost all the risk stratification except for the low intermediate class could be considered to start on the drug treatment and healthy living recommendation. And of course, with increasing trend in the risk of the major cardiovascular events, the drug treatment in particular can be different from category to another. So in the first place, healthy living, it seems for all. So all patients can be considered or should be advised to follow the healthy living recommendation. And the clear recommendation with the grade of evidence from the national guidelines, this healthy living should be an integral part of managing hypertension, whatever the class or the grade you are treating. And this recommendation in general can be displayed clearly in the following table. Here in this table, we can see from the left side the lifestyle modification, their exact recommendation and the target to be achieved on the levels to be considered, and their parallel impact on the systolic blood pressure reduction. This part, I consider it is the second part of this slot. Will be focusing on the pharmacotherapy recommendation and use of drugs. And in this slide, we can see the overall recommendation regarding treatment of patients with pharmacological treatment, and choosing either monotherapy or combination therapy based on the stage and based on the risk stratification that we highlighted before. And this is a target, the general one for most of the patient. And here in patients with high and very high risk, they can also get benefit from decreasing the target below 130/80. Combination therapy also, as a free or single pill, the fixed dose combination also can be recommended as a way of easing the adherence to the medication among this patient. Assessing the global cardiovascular risk is also important, as we mentioned in the first part of our lecture, that hypertension is one among the major cardiovascular risk factors. So overall, a comprehensive cardiovascular assessment is warranted, and co-manage patient in the primary care and optimize the care clinic attend. For those maybe the non-patient clinic attend, refer to the primary care clinics. In this part, we will talking about what actually can affect the choice of antihypertensive over another. In the first aspect, we will highlight the presence of the common therapeutic problems, adverse effects, or side effects that are associated with certain agents. For example, we can see the ACE inhibitor and maybe the cough or effect on renal or the rash, the ARPs and the headache, rash, and sometimes renal, calcium channel blocker, dihydropyridine and dihydropyridine. I think this one very basic. I think this pharmacology knowledge is very basic, but it is important part of considering customizing the therapeutic option in a given case. Here also the same. With diuretics, you have to think according to type of diuretic what actually the common problem can be there, and whether this one is if a concern to this particular patient or not. Okay, aldosterone antagonist, the beta blocker, the fatigue, and the impotence in given case, reduced exercise, sinus bradycardia sometimes, and the alpha blocker, which is maybe quite interesting to see. This one is maybe increasingly prescribed in the Malaysian setting. So in this part, which I consider very important, we can see how the treatment choices can be different or can be customized according to the concomitant condition. If patient with hypertension with diabetes, for example, with or without nephropathy, we see the largest evidence of recommendation about the ACE inhibitor group. And for gout, for example, because diuretics can cause, or some diuretics can cause hyperuricemia, we can see here to use with caution. Okay, and for example, for older adults with no comorbid condition, diuretics is one of the recommended antihypertensive in elderly, along with the calcium channel blocker and ACE inhibitor in case of the very elderly individual. This table is very important for us to understand the relative preference of antihypertensive agents and how it is affected by the concomitant condition in a given case. Here is another example of the concomitant diseases impact on the choice of the treatment. We can see here conditions grouped under the asymptomatic organ damage, left ventricular hypertrophy, the microalbuminuria, where ACE inhibitor and ARP is very recommended over the others, and also when we have underlying cardiovascular event, angina, for example, angina we have the beta blocker, one of the anti-ischemic agents. So in this case, with beta blocker, we have a relative advantage and CCP. In the stage renal disease or in the stage renal failure, where the ACE inhibitor or an ARP can play a role, a patient with arrhythmia, atrial fibrillation, ventricular control, or something they can benefit of the antihypertensive agent with rate control properties like beta blocker and 9-dihydropyridine CCP. In treating isolated systolic hypertension, you remember this one? This will increase with age and poor prognosis. In this case, we have diuretic and CCP as highlighted. So it is another way of understanding and highlighting how the treatment choices can be different according to the concomitant disease condition. Next is the severe hypertension or stage 3 hypertension, referring to the persistent elevation in systolic blood pressure more than 180 and or diastolic more than 110. It is either urgency or emergency, and both of them have been referred in the literature as hypertensive crisis. So one logical question, based on what the urgency classification will take place, or we say emergency, based on whether the patient is symptomatic at the presentation, which is usually the case in emergencies, and more important, the presence of acute organ damage and complication. This very diagnostic or unique clinical characteristics in the emergency compared to the urgency. And consequently, the blood pressure reduction rate in emergencies should be much faster. Can sometimes done within minutes to hours, and we can see how this maybe minutes achievement of reducing blood pressure also can be achieved within the recommended medication. So here, the emergency management algorithm for the patient just presented with this finding, this hypertensive crisis or severe hypertension. Okay, at the point we are not sure, so we go for the unique clinical characteristic, the acute target organ damage, and you see if there will be emergency, if no, will be urgency. If emergency, we have another underlying condition that make the situation more and more complicated, like aortic dissection or severe eclampsia or fake hemosarcoma, for example, these secondary causes. If yes, okay, so reduce by this recommendation during the first hour, and will be much lower if the underlying cause is aortic dissection. You can target for less than 120. If no other secondary hypertension causes, we can go by reducing the blood pressures around 10 to 25% within the first hour, and then try decreasing less than 160 within the 6 hour, and gradual decreasing can be there. And this actually was maybe parallel to the improvement in the clinical outcome, with the abrupt correction of the hypertension in patients with no other underlying condition like these secondary causes, was associated with worsening the clinical outcome. So gradual correction or gradual working on normalizing the blood pressure is very important to consider. Here we have the management algorithm for the urgencies based on the assessment that the patient has no concomitant target organ damage, and for this the patient can be resting with monitoring and checking for blood pressure and see whether the blood pressure reduction is there, so the patients can be assigned for the discharge later. If no blood pressure reduction achieved within resting and close monitoring, so this patient should start the antihypertensive and gradually checking the blood pressure every 30 minutes and see for further care. Okay, the question is, what are the medications to be considered for hypertensive urgency? It can be classified mainly. We can use oral antihypertensive that may be acting fast. One of them is the captopril, the nifedipine, or labetalol. Okay, captopril is maybe a common one. Nifedipine is not that recommended because of the sometimes it causes reflex tachycardia. Labetalol, one of the effective agents. Okay, and this is a discharge plan. How the patient will be scheduled for further care, for the home blood pressure monitoring and the frequency of the monitoring and the medication to be discharged on, and what actually the recommendation, the follow-up and the care. On the other hand, for hypertensive emergencies, where we have maybe high possibility or already acute organ damage and complication is there, so we have to achieve a faster reduction in the blood pressure, so mainly the IV medication is there. And one good point that can be considered in choosing among the various medication recommended for hypertensive emergencies is to look for the comorbid condition, the compelling indication. For example, patient with hypertensive emergency and they have an acute coronary syndrome. They have maybe MI setting and non-STEMI, STEMI, acute pulmonary edema, for example. For this patient, nitroglycerin is a good choice. Okay, labetalol, very effective, but sometimes we have to be cautious in acute heart failure. We have also another maybe a recommended agent for acute coronary syndrome, the isosorbate dinitrate. We have one of the vasodilator which is proved to be effective, the hydralazine, but to use with caution in acute coronary syndrome, even in patients with cerebrovascular accident. And we have also to take note that hydralazine, compared to other agents, the blood pressure lowering effect is to some extent unpredictable. We have nicardipine, caution in acute heart failure and coronary ischemia. We have esmolol, used in preoperative situation and tachyarrhythmias, one of the common agents to be prescribed in tachyarrhythmias in hypertensive emergency. So now we just, as a summary for the recommendation for the hypertension crisis or hypertensive crisis, we can say that the hypertensive urgencies aim for 10 to 20 SPP reduction after 2 hours. Treat the hypertensive urgency with combination oral agents, and you target to achieve at least around 25% reduction within the 24 hours. Treat the hypertensive emergencies with intravenous drugs, and reduce the SPP to less than 140 in the first hour for patients with the other severe condition, the preeclampsia, eclampsia, fear, chromocytoma, and for patients with aortic dissection, less than 120. Be careful that the reduction, the SPP, should not be not that fast, no more than 25 within the first hour, to maintain a good clinical outcomes in a given case. So in this part, which is the last part of this slot, we'll be focusing on the recommendation of the hypertension management based on the special population. Special population, actually, we have maybe selected the most common comorbid condition that need more detailing in considering the hypertension pharmacotherapy. First, and the most important, and we can say diabetes and hypertension latest data from my own research. Even we collected some data from we worked on project related to diabetes, and we found that 80% and sometimes 88% of our selected patients with diabetes have also hypertension. So it is high prevalence of diabetes among the hypertensive patient, and that's why we bring it as the first special population. We start the treatment if the blood pressure more than 140/80. ACE inhibitor, as we highlighted before, is agent of choice. Both of them are maybe more recommended, especially the patient have proteinuria is going on. Consider CCP and diuretic and beta blocker if we cannot give this RAS blocker for any other reason. You remember the contraindication when we cannot use ACE inhibitor. And the target for diabetic to be less than 140/80, and consider low than 130/80 if relatively younger patients are there. The second special population is patients with renal disease. In hypertension with renal diseases, we have to consider a few points. The number one, the extent of the proteinuria, and according to the extent of proteinuria, whether it is more or less 1 gram per 24 hours, you can set the target blood pressure. And also, you can consider the patient age and along with the proteinuria and the current GFR to also aim for further reduction. Related to the choice of the antihypertensive in renal disease, we can consider in general the RAS blockers, ACE inhibitor, ERP for patients with either micro or macroalbuminuria. And the non-dihydropiridine CCP can be considered if there is persistent proteinuria are ongoing. Also, it is important to consider the use of diuretics or the salt restriction in patients with CKD in general, because we have the determinant of the control of hypertension in CKD are both the water and salt retention. Also, there has been talking about the use of complete RAS blockade and the simultaneous use of maybe ACE inhibitor, ARP with renin inhibitor, and this one, the guidelines recommend against using this one in patients with CKD. Next, we have hypertension in patients with underlying heart disease, and of course, those with MI will benefit from this particular use of beta blocker, ACE, and ARPs for mortality benefit. Also, we have to initiate beta blocker, ACE, and aldosterone antagonist with patient heart failure with reduced ejection fraction for a mortality benefit, or for heart failure with preserved ejection fraction for reducing the hospitalization or morbidity. In general, RAS blockers in patients who are relatively old and has AF was shown to be having good impact. Any drug except beta blocker, it is not encouraged actually in patients with peripheral artery disease. Beta blocker is not. For this one, we can particularly give an ACE inhibitor in those particular patients, and thinking to make use of the antiplatelet in these cases. ARPs are usually a treatment of choice for hypertension patients, especially with those with left ventricular hypertrophy, for the benefit of the ARP in the cardiac remodeling. The target also has to be sometimes a bit different according to the condition, and normally or below the higher level, getting the blood pressure below the 140/90 is advised in this patient group, while going a bit lower, less than 130/80 is advised for a patient with left ventricular hypertrophy. And antiplatelet also should be there in this particular patient unless there is a clear contraindication. Next, stroke. Hypertension in stroke is usually a topic of interest. Stroke to be prevented, as in primary or secondary prevention, hypertension should be well treated, and maintaining the blood pressure below the high level, below the abnormal level, is advised for primary and for secondary prevention. And for secondary prevention, actually, we can use ACE inhibitor and diuretic as a preferred agent in this context. In patients with lacunar stroke, the lacunar vessel in the brain, more reduction in the blood pressure also can be advised for secondary prevention for blood pressure target less than 130/80. In acute ischemic stroke, the recommendation is a bit different because relatively high blood pressure is needed to maintain the brain circulation and avoid the brain ischemia in the given case. So in the first 2 weeks, advisable not to go down 180 in case the patient has no coexisting hypertensive emergencies out there. Abrupt lowering for the blood pressure is generally not advised, and the use of supplemental nifedipine in this case is not recommended. Patients are not advised for aggressive lowering the blood pressure less than 140 within the first 6 hours after the hemorrhagic stroke, and the blood pressure should just be maintained less than 220 in this case. And aggressive reduction should only be considered if the blood pressure exceeding 220, and in this case, the intravenous antihypertensive will be initiated and with frequent monitoring. And for this point, just to highlight that the 180 to 120 is also modulated by the other management given for the acute ischemic stroke. For example, and in the first place, the concomitant use or unuse of fibrinolytics. This actually will affect the target blood pressure that we are aiming to. What about the elderly, the older adults? The older adults, as we mentioned, I think we have some highlights in the previous slides, but we will maybe doing close follow-up and monitoring for this patient population, assessing for the common problem in the elderly and its potential association with the used antihypertensive is also a point to be considered. The risk of falls, the virality, the postural hypertension that is associated with some classes of antihypertensive, and the approach should be individualized as much as it is applicable in the clinical scenario. We can see here for the target blood pressure in older adults, it will be different according to how old is the elderly. Okay, we can see, for example, the senior elderly patients more than 80 years, the target can be less than 150, while the relatively younger population, 65 to 80 years, can be less than 140. The fit patient from this category can be considered even for less. But in general, the concept is following a less strict target in patient, the elderly patient who has a risk of virality, falls, cognitive function, functional impairment, multiple comorbidities, because the safety in this patient group are of a concern. And that's why one of the recent reports have tested that the impact of deep prescribing the antihypertensive on the overall safety outcomes among this patient population. Next are the women, and when we talk about the women, we're interested to highlight the medication that in the first place cannot be given, like the RAS blockers, cannot be given in general for any woman with a childbearing potential. So knowing that these are contraindicated, so what is recommended? So the first line is still in the pregnancy to use methyl-dopa. Labetalol can be also alternative, and a second line nifedipine can be prescribed. In acute setting of hypertensive crisis, the IV labetalol and alternatively IV hydralazine also can be used. Last, we have maybe a brief overview about resistant and refractory hypertension, and the difference between both. Resistant meaning hypertension that cannot be controlled by three or more medication, including diuretics, while refractory refer to hypertension that cannot be controlled almost by 5 or more antihypertensive medication. Okay, so what if the blood pressure can be controlled in four or more? This can be called or classified under the controlled resistant hypertension. In this category, it is advised to look for potential non-adherence or secondary causes that is there. Treat patients with at least 3 drugs, inclusive a diuretic, before you set a diagnosis or before you mark this patient as resistant hypertension, as per the definition we mentioned. Spironolactone, when it is a fourth agent to be added, spironolactone should be considered. And for this, with refractory, means 5 or more antihypertensive is no longer working. In this case, a device-based therapy can be indicated. And one example of this one, the renal thrombostatic denervation also can be considered. With that, I thank you so much for following this video lecture, and I'm welcoming all the comments or queries either on our learning management software, iTalim, or in the comments in the video. Thank you so much.